25th, 2023. I'll call the roll, please.
Commissioner Carl Boyd. Here. Amber Brown. Suzette Couples. Holly Deering. Brian Gaither. Mary Hickerson. Lois Miller. Commissioner McAdoo. Commissioner Phillips. Shantae Sherrill. Michael Smith. Steve Spence. Sonia Stevenson. Eric Tutobeni.
Thank you. We have a quorum. Ms. Hickerson, have you had a chance to review the minutes?
Yes, sir.
We have a motion on the minutes. Do we have a second? Second. We have a second from Mr. Spence. All those in favor of approving the minutes say aye. Aye. All those opposed? The ayes have it. The minutes are approved. Mr. Elam, financials, please.
Yes, sir. So Fund 264 for the month of April, your revenues $1,759,310. Expenses $1,938,026. For the total for your calendar year is $8,716,475. Expenses $13,107,802 for a negative revenue less expenditures $4,391,327. And for the fiscal year comparison, you have revenue at $47,001,315. Expenses $54,145,990. Revenue less expenditures, a negative $7,144,675. On the 266 fund for the month of April, workers' comp, you had $0 in claims. OJI, $62,101.93, and that was your total. Year to date, workers' comp, $1,358,957.31. OJI, $468,935.33. Total for the fiscal year, $1,827,892.64. And that concludes my report, Mr. Chairman.
Thank you. Any comments or questions for Director Elam? Seeing none, I'll entertain a motion to accept. We've got a motion to approve. Do we have a second? Second. We have a second. This is a roll call vote. Call the roll, please.
Commissioner Boyd. Yes. Amber Brown. Suzette Couples. Brian Gaither. Yes. Mary Hickerson. Yes. Lois Miller. Yes. Commissioner McAdoo. Yes. Commissioner Phillips. Yes. Michael Smith. Yes. Steve Spence. Yes.
Thank you. Motion passes. Let the record show that Ms. Brown has showed up. Thank you. We need you desperately. OSHA report. Ms. Thompson.
This is the OSHA report for April 2023. The total number of incidences was 18. That brings our year-to-date total to 89. Of that 89, 58 were OSHA recordable with 9 lost day claims, 37 restricted day claims, and 12 other recordables. On the next page, you'll see the comparison of the total claims year-to-date for 2023 of 89. 2022, we had 54, and 2021, 65. The next page is the on-the-job injury incurred dollars. For 2023, we're at $325,000. 2022, we were at $192,000. In 2021, $262,000. And on the last page, you'll see the breakdown of the 18 claims. There was 13 at the Board of Ed, 5 at County General, and of those at County General, there was 3 at the Sheriff's Department and 2 at Fire and Rescue. And that concludes my report.
Thank you, Ms. Thompson. Are there any questions?
Just one, if I might ask.
Yes.
The number of injuries and the number of dollars are going up, escalating a little bit, and I realize that the pandemic in 2020 had an influence on that. Also, more employees and higher at-risk situations. I'm just wondering where our total incident rate stands. Is it going up, or is it going down, or is it about the same?
For this year, I haven't calculated the incident rate. I don't have the total man-hours worked. It's usually done on an annual basis. So for last year, our incident rate was still at 2 point something, which the state was at 4. So we're still about half of what the average is for the state incident rate.
So there's no way that you can calculate that quarterly or every month or any
We
of
can
that
look
kind
into that to see if we can't get the total man-hours worked based off of the quarterly periods.
I've always known that the total incident rate is the gauge for how you're performing versus dollars that you spend or total number of accidents that you had. So if it's a way to calculate that on a more regular basis, I would like to see that.
Yes, sir.
Let me follow up with that, if I may. I think that's an excellent point. For the information to be of current value, if there's an opportunity for us to get, for lack of a better term, a run rate on incidents as it relates to a percentage of employees and this kind of thing, it might be helpful, especially in those departments that are seeing an uptick in violations or reports, if that makes sense. Not to burden your office unnecessarily, but if you could come back to us with an idea of what that would look like as a monthly or a quarterly report, and then that way it certainly gives the office of the mayor time to get to those departments that are seeing an uptick. I think that's where you're headed, it's some preventive measures, and it'd be reflective in those filings, if that makes sense.
That's one thing that our department has been doing, is visiting more departments. We've been out to Highway, the Sheriff's Department, Correctional Work Center,
Solid waste.
Solid Waste. We've worked with PAWS very much in reducing their,
Okay,
Schools.
outstanding.
we work with the schools and give them some different reporting, and with their maintenance to make sure that anything maintenance or safety related, that they can address that quickly.
Okay, excellent.
Where I was going, the total incident rate is a government standard that you can gauge your performance by against like industries, and judging ours against other counties is exactly the gauge that we should be comparing ourselves to. Highway Department, Sheriff's Department, others that you talked about, in my mind, are performing exceptionally well. And I think we're doing accident investigation and prevention techniques to see that reoccurrences don't happen. It appears that the school board, their numbers are going up, and I know they have a lot more employees than they've ever done before. And I think we've asked for this before: what kind of an accident investigation process do they have? And I don't think we ever got a really good response from that. I'd like to know if it's possible that we could have whoever's in charge of their safety process at the school board could come and explain to us what their accident investigation, and then to summarize their process that they have as it relates to implementing procedures to see that similar accidents don't happen in the future.
So our office investigates the accidents for the schools and county general. We work with the maintenance department to get video footage, the principals, and with Monica Ridley and Dr.
Jeffrey.
Anthony, as well as
Jeff Reed.
remember her name? Yeah, Jeff Reed. And there's another lady, her name escapes me. I think it's Anna Ralston, that we work with, reporting to them monthly incidences so that they can evaluate that further in the schools and see what training, additional training might be needed, or areas where they're looking for funding to be able to provide that training for the teachers for particular types of incidences.
So they are reporting every accident has some type of conclusion that relates to this is the cause, and this is what we're going to do to try to implement a process to prevent that from happening. I know a lot of them are slips and falls and are hard to correct, but still, all in all, if we don't do anything about it, they're going to continue to rise. at an unacceptable rate. And that's the reason that the TIR is so important, that we take a look at that on a more regular basis.
Yes, sir.
And Susan, if you don't mind, will you discuss the part about the reduction in lost days? And this goes into the investigations, the follow-up, and also working with, and you know, a good shout out to the department heads and the schools. Anytime you have an injured employee, a lot of people think they just want to sit at home and watch TV, and it's so not true. Most people want to get back to work, and so our office works very hard, and Susan's pulled some statistics for us.
So one of the things I looked at was the number of claims versus OSHA recordable. So OSHA recordable means the treatment was beyond first aid. So of the 89 total incidences, 31 were no more than, they were less than first aid or less. They didn't go beyond that. So that's about a third of the total incidences didn't require but maybe one visit to a physician. Also, our OSHA recordables based off percentage of incidences decreased by about 10% over last year. As well as our lost day claims. Our average number of days an employee was out for an injury last year was 19 days. This year so far it's 14 days compared to the same time last year. So.
And the incurred dollars, you have to be careful when you look at that because of inflation. They've raised, anytime somebody sends a claim in, they assign a certain number. Well, that number has jumped up due to inflation and stuff like that.
Yes,
so it's
sir,
not really comparing
on.
year after year to apples based on the number that they have. But if you look at the 266 report and you look at the OGI for the last 3-4 years, especially the last 3 years, in comparing to the additional hours worked than people that have been hired, total hours worked. You know, you're at 468, 935. I think if you did that in comparison to the additional hours worked, meaning people hired and people having to work overtime, you'd see that ratio is not out of line as much compared to last year as the numbers look like they are.
Thank you. I appreciate that report. Once again, the total incident rate should be our report card, not the dollars that we spend. If the total incident rate is within line or even reduced, dollars will come down eventually.
Yes.
That's the reason that I'd like to see what that is, maybe on a little bit more often than an annual basis.
I think that now that payroll's through next gen, that's probably a report we can more easily get than on just on an annual basis. So I'll work with them to get exactly what report we need and get that figured for you and present that to you next time.
But keep in mind, the state, I don't think will release their incident rate for 2022 until November.
That's correct, for last year. So we can at least report on what ours is
But ours
more,
is, but
more
not
regularly.
But the comparison will be hard because we won't have that till then.
Any other questions for Ms. Thompson? Seeing none, I'll entertain a motion for the OSHA report. We have a motion by Ms. Higginson. Do we have a second?
Second.
We have a second. This is by acclamation. All those in favor of approving the report say aye. Opposed? The ayes have it. The report is approved. And now we go to the wellness update. Ms. Lovett? Thank you. My apologies.
That's okay. Good afternoon. So for our total incentives that have been earned for May of 2023, we are at 381, and that is, if you want to compare that to last year at the same time, we were at 348, so we're a little ahead. And along with that, we just recently had Rutherford County had their analytics report meeting with Cigna, and the report showed that chronic individuals are a significant driver of medical costs and reduced productivity. So the three highest categories as of 4/30/2023 were depression, diabetes, and weight complications. So since the beginning of the year and continuing forward, we have really been trying to promote those last three incentives that you see. The health coach, there's two different health coaching, one with chronic and one for lifestyle, and then the diabetes program. So we just want to, if you have the opportunity, just to remind these employees that we have these programs and we're really hoping people try them out. Next week, we'll be releasing our communication for our monthly podcast, national health awarenesses, and other topics. And to end our wellness challenge for the second quarter, we tried something new. We did a virtual raffle prize giveaway. A lot of people had great feedback from that. Moving forward to next month, which is next week, we'll be doing our annual Wellness on Wheels. A lot of y'all are familiar with this. We will be reaching out to every department to set up a time. We might come out, depending on what the department requests. Typically, it's 30 to 60 minutes that we'll sit, and we'll be there for anybody that wants to come by and consult with us. But the main goal of it is to promote people getting their health assessments, promote people getting their health incentives and preventative screenings. So be looking out for that. We will be contacting everyone in June, and we will be going out in July to do those. And lastly, we'll be trying a email campaign. I haven't done any of those. Most of them have been on site this year, to promote people just knowing their numbers and knowing where they stand with their health. And that concludes my report.
Yes, sir.
One quick note, Liz, you might just mention, part of the reason maybe for the, maybe like the 10% uptick in the wellness completion goals met is that y'all have already been around to most all departments. You might let them know, again, trying to promote getting your points and some things like that. So you've already made one round. What was that?
That was
March, April?
Yeah, so yes, sir. Last year, it still kind of was on hold about visiting everyone because, people, we're still trying to get on board after COVID. So like he said, we got to go out and do biometrics campaign already to most of all the departments. And obviously you see that made a difference. So I do know last year there were a couple departments. Usually it was mostly because they said, well, we only have 3 or 7 people. You don't need to come. But hey, every person makes a difference. So we're happy to come. That's what we're here for. So whether you have 3 people or 50 people, just let us come by and make that contact with everyone, because it does make a difference.
Any other questions? Commissioner Phillips.
I've asked this question before, but I'm probably not smart enough to make intelligent notes or remember. The wellness program, who is eligible?
Everyone under the Rutherford County Medical Plan with Cigna.
So employees who are not part of the plan are not eligible?
Well, that's a good question. So a lot of the things I do offer wellness challenges, lunch and learns, campaigns. Most of them are for just Rutherford County employees under the medical plan. However, there are some things I do offer, like the wellness challenges. Anybody can be a part of it. The goal is to get a good morale of your employees in your department. And now they might not be eligible for all the prizes or like the free lunch and learns, because that comes from the group that's paying into the medical plan. But they are still able to come, be a part of it, have a free coach that's guiding them and encouraging them, because it might influence another person that is on the medical plan. So we try to balance it out the best we can to be fair, on both sides. Like I said, mostly just to promote overall happy, healthy employees. But did I answer that well enough?
It was a selfish question, yes. Thank you.
You want to be a part of it? Well, I'm sure we can work it out. Yeah. Jennifer will add you to the emails. Yes.
Any other selfless questions? Yeah, Ms. Brown, you're recognized.
I don't have a selfish question, but I'll say I'm just more curious because I know these health coaches and kind of the bottom 3 are new programs. Does your department just benchmark participation just to see if you're going to continue that for the next year?
We're just
these last 3. So I'm looking at the health coach.
So you're saying
goal and the chronic health problem, those 3, and I only see your participation now as 1 because it's a new program. But I'm just curious if you're going to be tracking participation.
Okay, so yes. So those are, and that's a good question because those are harder to read. So for instance, OMADA, for instance, we, all of those last 3 are like the OMADA's 16 weeks. So even though there might be 15 people enrolled, it won't show up on the report until they're finished. So I reached out to them recently, and it's the same for the other 2. I think the health coach and the chronic one's a little bit different. Let's just say it's like 12 weeks. They won't show on the report that I have 20 people enrolled, but it'll show when they're done. So it kind of, and I don't like that either, because of that, I reached out to OMADA just to say, hey, how many people just enrolled since October, since we go from October to September in our incentive points? And they said we had like 15 enrolled, and I believe it was, and I'm going off the top of my head, so I might be off 1 or 2, but only 5 have completed 10 weeks, and only 1 completed the full 16 weeks out of that 15. And is that what you meant?
Yes, I was just curious
Well,
from
me
just
too.
a benefit, right? Because you don't
Yes.
want to just have programs, and then if we need to kind of push more in an area, it's just good to know.
Yes,
there's-
and I found it very interesting that I hate to be able to come here and say, oh, I have 0 and 1 and 1, because how many people are actually doing it? It's a long time frame before I can show it in my report, but we do. But please, if y'all have the opportunity to remind them, just, it can't hurt to try, for anybody to try these.
Any other questions? Thank you, Ms. Levitt.
Thank you.
Next on our agenda is Ms. Beth Wilson, Manager of Business Operations for MedPoint.
Hello. Good afternoon. If you'll turn to page 3 to review the visit analysis for April for the MedPoint Clinic at New Salem, you'll notice in the visit summary that the unique members seen were 120, which was 86% of the total visits seen of 138. We did see a significant drop in the number of visits that were seen. A lot of this is due to one of our nurse practitioners leaving, a new nurse practitioner coming on board. There was a gap, and so we saw a decrease in visits, unfortunately. On page 4, this is a new slide for you all. What we did is we went back to 2022 to do a comparison. We took out the Board of Ed numbers so that you could compare Rutherford County's usage against itself from 2022 to 2023. You'll notice that in January, comparing the two, we had 2 additional for 2023, February 51, March 97, and then of course with the drop in usage in April, we had 13 less. I feel like this will change as people are getting used to the new practitioner. Page 5, the visit summary by member type. We had 21 children seen, which accounted for 15% of the visits. 93 employees seen, which will account for 68% of the visits. There were 24 spouses seen, which would account for 17% of the visits for the month of April. On page 6, visit appointment type summary, 17 members had 2 to 3 visits, which was attributed to multiple health reasons. The highest appointment type that was used in the month of April was established patient, which was 96. We did have several annual visits that were seen in April, followed by new patient visits of 12. On page 7, the visit summary by day, there were 20 scheduling days in the month of April, with Monday being the busiest day of that month. On page 8, in-person versus virtual visits, we had 1 virtual visit for the month of April, which is down from the 7 that we saw in the month of March. On the next page, the in-person versus virtual, you can see a comparison. You'll notice that the in-person continues to hold the largest percentage. We do offer virtual to anybody that is interested in it, so we do not discourage that, as long as it's, medically appropriate for them to be seen virtually. So as you can tell, people are getting back to wanting to do in-person. On page 10, our referral summary, we had 27 referrals, with cardiology hitting the top referral, which is new to our referral summary, followed by sleep medicine, orthopedic surgery, gastroenterology, and dietitian. On page 12, in April, there were 120 unique members. Total operating cost of $37,754.31. Employee count was 1,938 for a PEPM of $19. Again, April significantly lower because we had a decrease in salary with one APP leaving and a little bit of a gap between the new one coming on. And then if you'll turn to page 14, BMI summary. Female highest percentage BMI is in the obese class 3 category, and male highest percentage of BMI is in the overweight category. Page 15, diagnosis codes. Encounter for general medical exam and sinusitis, pharyngitis, allergic rhinitis were the top diagnosis for not only the month of April, but we also saw them hitting the top in February and March. Page 16, visit demographic summary. In April, 64.49% of the members seen were female. The female population continues to show the greatest usage of the clinic. And that concludes my presentation.
Thank you, Ms. Wilson. Does any of the members have questions? Yes.
Yes, I have a question. I was noticing as you were going through the various grids and the number of appointments that the grids top out at 250. So is that the total monthly capacity for appointments? And since we weren't really there at that 250 in each of those, so I didn't know how close we were to our total monthly capacity. And are we currently funding hours for staff when there are no visits scheduled?
So we have not topped out in capacity. So there is capacity to add additional patients as needed.
Is that the 250?
Yes. And then, I'm sorry, the last question you asked me?
I wondered if when there were no appointments scheduled, is the county still funding the hours for the staff involved?
So yes, the county does fund that, as we are committed to being open for walk-in patients. And so we keep our staff there during the hours that we have agreed to, so that if someone needs to walk in, we have staff available for them to be seen.
Thank you. Any other questions?
I have a question.
Yes, Mary?
Over where you had the count on appointment types, and we had 96 established patient visits and then 16 annual visits. Of those 96, is that, are we taking into account, is that possibly someone starting on their wellness points, or are y'all putting anybody that is working towards wellness point under an annual visit?
So if they are coming in for just their annual visit, they're going to hit that annual visit. If someone is coming in and they're just trying to get, I don't know, order for, let's say, a mammogram, it would fall under a established visit. Okay.
Anything else? Thank you.
Right.
Next, Mr. Paul Huffman with Cigna. I got a question for you, Mr. Huffman, at the appropriate time. I'm sure you're going to be able to answer it, but I'm going to let you do your report first. Thank you, sir.
Thank you, Mayor, and good afternoon. Excuse me. Please forgive me for my voice this afternoon with the allergies and colds. Hopefully the NyQuil and DayQuil concoction will not make me delirious when I talk. So there's a 4-page document that you should have been given that is a brief, very brief summary of a consultative analytics total health insight that we recently conducted with the benefits team at Rutherford County and the Gallagher team at our office earlier this month. Lois was also there. And so consistent with what we've done in the past, I want to just give you a couple of pages overview. If you'll turn to page 2, just some framework around the foundation of the data that we're looking at on this page down at the bottom left. So what we want to do is kind of create a picture, a comparison of calendar year 2022 versus calendar year 2021. And so we'll do that through this data. We will separate the claims into what we call catastrophic and non-catastrophic claims. Catastrophic claims being anyone who has a claim any claims during the year that total over $100,000 for that individual. We'll consider them as a catastrophic claimant. We also compare to your peers, your normatives, and we use our public sector norm, and that's all of our existing Cigna business nationally for our public sector, municipality, government clients that we have across the board. And we're also going to only look at those that are under the age of 65. So we've removed Medicare population from that normative. And the last piece is, just so you're aware, we did go ahead and remove the Board of Education from this data, so this is just county government data. And so now we'll turn to page 3 and look at the overall comparison. So from this page you can see we break out medical and pharmacy and also the total. So in the top left box there you can see that medical trend was actually down this year, or 22 over 21, was down 7.7%. And in fact your total claims per member per year for medical are below the norm, $5,000 for Rutherford County, $6,000 for the norm. Pharmacy, however, did increase from year over year of approximately 22.6% year over year, and that still remains relatively close to the norm, so you're just now exceeding the $2,000 per member per year, whereas our normative is around $1,975. When you combine all of your claims all together year over year, we've got a pretty good result. So we're looking at a negative 0.7% trend year over year. So your county government population claims overall stayed relatively flat for 2021 to 2022. That's a pretty good story. We are seeing trends in our book of business anywhere from 5 to 10% across our book. So to be flat is very good. Across the top of the page, you'll see the membership changes. Membership stayed relatively the same, down 3.4% year to year. Your contract size, so for every employee you have on the plan, you've got another dependent on average, so there's 2 per contract. You are about 51% male, 49% female, and your average age for all your membership is about 31.9. In addition to breaking out claims for medical and pharmacy, we also break out pharmacy in 2 ways. We break out pharmacy, we look at it specialty pharmacy and non-specialty pharmacy. Non-specialty pharmacy are the drugs that typically are obtained through the pharmacy, through retail. And specialty drugs are those drugs that are used to treat chronic conditions that are very expensive, a lot of times more than $300, $400 a prescription. Specialty pharmacy is what drove most of that pharmacy trend of 22.2%. Specialty pharmacy was up 45%. So we talked a lot about that, and I'll go through that on the next page. The one good news, another piece that helped keep that trend low was the fact that your catastrophic claims were down from year to year. Minus 5.5 trend. So your claimants over 100,000 actually reduced. So we saw a very good trend from that perspective.
Mr. Huffman, can I interrupt you for just a second?
Yes, please.
You said something a minute ago about specialty pharmacy drugs and those that were not specialty pharmacy drugs. Is that correct?
Correct.
Two real quick questions on that. Who makes the determination about what a specialty pharmacy drug is? And how do you move and who makes the determination about whether that particular drug or treatment is moved from specialty to non-specialty?
So they won't move. So if it's a specialty medication, it's going to stay specialty medication. Specialty meds are typically made from a protein. So it is a highly biological medication. So it's not something that a generic typically can be made to duplicate. So you won't see them go from one to the other. And typically when you have a specialty med, it is for certain life-saving type conditions, cancer, things like that. So it's not going to switch back and forth.
Thank you.
You're welcome.
Sorry to interrupt.
No worries. Okay, we'll turn to page 4. So this page does a quick review of pharmacy, and like I said, we talked a lot about this because over the years, we've done this meeting with Rutherford County since you've been with us, so almost 20 years, and we've always talked, or we've always knew in the future, specialty medications were going to represent almost 50% of your drug spend one day. We used to say that 10 or 15 years ago, and we thought, oh, that's going to be crazy. Well, you're getting there. I think specialty spend right now of all your pharmacy is roughly 44% of your total pharmacy spend. And that, like I said, that's expected. Our book of business is 48%. So you're still not quite to what our other clients are at, but all of our clients are experiencing half of their drug spend under that specialty category. That's not necessarily a bad thing because these are drugs that you want your membership to take. And these are drugs that typically prevent people from going into the hospital and having very, very large claims, prevent people from going into the emergency room and having large claims. So even though they are expensive medications, they are still less expensive than what the alternatives would be had they not been on those medications. The top right pharmacy snapshot gives you a per member per year broken out, like I said, for the total pharmacy, broken out for specialty, and broken out for non-specialty. And as I mentioned before, you're very close to the norm, your other public sector peers throughout the country. And as you can see, specialty meds, even though it went up 44%, you were so significantly low last year that it does represent a very large increase, but yet you're still below what we would see as the norm. So you're just now catching up to what is probably more norm, if you will. In the top middle box, we break out that 22% of pharmacy trend. And that's broken out. 2.5% is inflation, so that's just the increase of manufacturer cost on drugs. Your utilization increase, that's the increase of days supply for members who are taking the medications compared to last year. And then drug mix is the primary cause of the inflation, or the primary driver of the 22.5% trend. And drug mix takes into consideration what I just mentioned, all those more expensive drugs being taken than were last year. So it's a drug mix change from last year.
Mr. Huffman,
Yes, sir.
May I ask another question, please?
Please.
Thank you. These specialty drugs, is there a particular class of specialty drugs that we saw a greater increase in their use from last year to this year that we can kind of get an idea of the types? Well, was there a particular class of drugs that showed a remarkable increase as opposed to some others?
Yeah, exactly. Very good question, and that takes me to the top right box. So when we look at the trend contribution by class or types of drugs that Mayor Carr is asking about, we saw, so in other words, the 22% trend, 10% or almost half of that was due to anti-neoplastics. So we are still seeing cancer specialty meds prevalent within the plan. And obviously those are the types of specialty meds that are infused in the office, blood cancer, anything like that. So that represented 10.1% of that 22% trend. In the green box coming down, we have a lot of interest in these new drugs that we're seeing on TV. The Wegovy, Saxenda, Ozempic. There's a lot of confusion about these drugs, but we are seeing an increase in them. These are what are categorized as GLP-1 drugs, and we're talking about these with most of our clients. Keep in mind, when someone has a diabetic diagnosis, a doctor might put them on a drug called Ozempic or Mounjaro, and that drug is designed to help with their diabetes. It's also considered a hypoglycemic, and so you can see that in the orange box there too as one of the ones that increased. Cigna does a very thorough prior authorization for those drugs. Not anyone can be prescribed those drugs because it's very popular right now for people to take diabetic drugs like Ozempic and Mounjaro for weight loss, and people are sometimes even paying out of pocket for these drugs because they're so effective at weight loss. But those two drugs cannot be prescribed for weight loss off-label on the Rutherford County plan. And so we do a very thorough prior authorization to make sure someone does have a diabetic diagnosis on the plan before they can obtain those. Secondly, if you see in this box the green, well, why do I have weight change drugs listed there? Well, Rutherford County does have a weight loss buy-up medication and weight surgery included on the plan. So you are paying for services to help people lose weight. The good news is there are derivatives of Ozempic and Mounjaro. They're called Wegovy or Saxenda, and those are FDA approved for weight loss. Okay, so we are prescribing those for people who do qualify and have a medical necessity proven for medical weight loss. And so that's where you can see those are showing up in the green. So all that to say, we are seeing an increase in those drugs. We do feel that over time, probably over a 3 to 4 year period, if people are maintaining those weight loss type drugs, that you will start to see a return on investment because they are expensive. A lot of our employers do not cover them. And so we are seeing that, but we do feel that the weight loss will impact diabetes or the diabetes risk, also the hypertension.
If I may, so I am thrilled that you brought up those particular drugs because all my questioning was toward that end.
I had a feeling.
Well, you feel correctly. Because, and I want to go off on just a small rant for just a second. The mayor's office, the county commission, and all departments within Rutherford County take their employees, the health of their employees and their families extremely seriously. And I cannot state that strongly enough. And I think it's understood that weight is a significant contributor to a number of illnesses, not confined to diabetes and these kind of things. And we're talking about significant weight. We're not talking about 10 or 15 or even 20 pounds. We're talking about significant weight gain, and it has significant adverse health issues. The FDA approved these drugs 2 years ago for use for weight loss gain. And I understand they're expensive, but I also understand the cost to treat the ancillary effects of being overweight are much more expensive than it is to prevent. Is there something that we can expect from Cigna going forward to make these drugs available for people with significant weight issues, chronic weight issues, weight management issues, that make them more affordable so they can participate in healthier lives?
I would say from a perspective of affordability, we are always willing to work with the manufacturers in negotiating and see about obtaining manufacturer assistance in all cases possible. I would caution, I'm not a clinician, I typically repeat what I've heard from the experts, the doctors and the clinicians in our office, but there is still some things yet to be determined with regards to some of these new medications that were approved. There are comments regarding some side effects that may be undesirable. Even with weight loss, it's not necessary. They're seeing some muscle weight loss with these as well, not just fat weight loss. And then some are even now investigating some risks of pancreatic cancer that might be associated with some of them. So we don't want to go too far or too fast. We are following the FDA guidelines on these, using the ones that are prescribed for weight loss and not prescribing off-label the ones that are not. So.
And I appreciate that. And I know there's a balance here, and it has to be under the supervision of a physician. So I'm not advocating for a second that we remove that process. What I'm asking for is, can we expect from Cigna to have a serious conversation about making the affordability of these particular drugs to increase the wellness of these people so that they can have access to them?
Oh, absolutely. Definitely.
Thank you, sir. I look forward to those continued conversations. Please continue with your report.
Thank you for that. So moving down to the left, I'll finish up here relatively quickly. So we also look at medication adherence, and as you can see on the far left, all four of the categories are in green. So you're slightly above the norm or your peers with regards to medication compliance under hypertension, diabetes, depression, and cholesterol medications. Cigna likes to take a little bit of credit for that, because when we see that individuals may be skipping medications or not filling medications, we do send out letters for gaps in care. We send letters to the member, we send letters to the physician so that they are having that conversation, and hopefully we can close that gap, because we know that through medication adherence, again, you're preventing that chronic condition from getting worse and causing some type of acute condition that might cause a hospital need or an emergency room. And then last, I'll move over to the far right bottom box, and just some trends and observations that I'll read off quickly here. Your generic utilization increased almost 0.5%, and for every 0.5%, you can see that saves the plan about almost $150,000 every time generic medications are used when their brands are available. Diabetes accounted for 35% of the non-specialty drug spend. Hypoglycemic spend increased 18%. We talked a little bit about that just a minute ago. As you know, a couple of years ago, we put in the Cigna 90 Now, and that also offers a reduced or a better discount for those drugs that are obtained through our 90 Now network, and that saved over $140,000 to the plan. One other thing I'll point out, and you should have received a communication on this at some point from somewhere, but Cigna has now partnered with GoodRx. If you recall, that has always been a question on everybody's minds. When should I use GoodRx? Well, can I use that with my Cigna insurance? Well, now the answer is yes, and you really don't even have to think about it. So if there is a GoodRx coupon savings available to you when you fill a generic prescription at the pharmacy, it will automatically be applied, and you will get the benefit of that lower discounted cost, and it will also be fed to Cigna so that we see that you're taking that medication. And then lastly, just on the horizon, be aware, we talked about specialty meds. One of the ones that I didn't speak about was Seborrhea psoriasis. We've always seen the drugs Humira very high on the list for utilization, high on the list for cost. We're anticipating about 9 what we call biosimilars coming to the market during 2023. And as they come to the market, we will evaluate them with our clinical team and decide which ones we will prefer on the formulary so that people can start taking a biosimilar to Humira at some point. And it's not exactly like a generic because, like I said, specialty medications, you can't really get a generic, but they are formulated in a way that will provide the same efficacy as the specialty meds. So we're really excited about these biosimilars coming to market later in the year. So that concludes our summary. Any questions?
I have a question.
Yes.
Back up to the trend contributions by class where you were talking about the weight change drugs and the diabetic drugs. So of the 4.1%, that Ozempic diabetic medicine, it is listed there for diabetics only, the people that are trying to get it for weight loss. And the reason why I ask this is on a very personal level for my family, we went 7 weeks trying to get Ozempic from a drugstore. I called, I went around because they were sold out, because folks realize they can lose weight, and we have to have it for diabetes. And it actually ended up for about 2 months screwing up the sugar counts and everything for my family member, and we got in a mess before we finally could get this. So is that 4.1% showing just the folks wanting it for, or not needing it, getting it for the diabetes, and or is that part of the ones that are also slipping in and getting it for the medical? Because we did go through this whole big thing of having the doctor send the letter in, and which totally understandable, and we had to do it on 2 different ones. And so I just want to make sure that, you know, what is counted in that 4.1%?
Yeah, no, good question. So the 4.1%, there's nothing that slipped through. So that is those that obtained the Wegovy or Saxenda, which is FDA approved for weight loss. So since you cover that on the plan, that's legitimately showing up here. The hypoglycemics GLP-1s, which is the Ozempic and Mounjaro, you weren't alone. There was a nationwide shortage of those medications, and it was due to the fact that people were taking it strictly for weight loss, and the people with diabetes couldn't obtain it. We did have success. We had several clients ask us if we could help. We could not do a data analysis of our pharmacies and say, hey, go to this one, they have it. It just wasn't, we weren't able to do that. However, we could tell our own pharmacy, which is Express Scripts Home Delivery, whether we had supply or not. And every case that came across my desk, we did have supply. So we were able to get that person converted from CVS or Kroger and moved to home delivery and got them that medication. So that may be an option if it raises its ugly head again.
Thank you. Mm-hmm. I have a question too. Again, the specialty trend, as you noted, is significantly high. And can we expect our specialty trend to decrease as we approach the norm, or as the new drugs out, will the new drugs come out, will the specialty trend continue to stay pretty significant?
It's a good question. So, you know, like I said, 15 years ago, we were saying it was going to reach 50%, but what are we saying now? Is it going to reach 60, 70, 80? I'm not hearing that, okay? I do anticipate that the fact that you've now reached the norm, I do anticipate that your specialty trend is not going to increase at this level any further. However, by saying that, there's 2 things fighting against each other. One is more drugs coming onto the market to address new conditions, new drugs that we haven't seen. But then the good news is we have those biosimilars that we've never had before that are coming in to save money. So I do think that is what's going to mitigate that trend going forward, to prevent it from making specialty 60% of your total spend or 70%. It may end up being that one day, but right now we're still hovering around this 48% and have for the last couple of years. So, yeah.
Any other questions? Seeing none. Thank you, Mr. Huffman. Thank you very much.
Thank you.
Got one more.
Yeah.
Oh, I'm sorry. Yes, you do. Medicare
I think
Advantage.
the Medicare Advantage.
Yeah, I think
My apologies.
my name is associated with the Medicare Advantage rates.
One more.
I didn't bring that sheet. I think the team has added that to the, that's fine. I know what it says. The good news is the Medicare Advantage rate for 2024, we can go ahead and kind of give an outlook on that even before CMS gives us their reimbursement confirmations in June. So we are confident that the rate will be unchanged and there will be no rate increase to the Medicare Advantage rate for 2024. That's it. That's okay. Thank you.
Any questions? Now you're done. Thank you, sir. Thank you very much.
Thank
You've been
you.
very helpful. Last on our list is, we're going to talk about rates with Ms. Smith and Gallagher, as always.
Good afternoon. I'm Marissa Combs-Smith with Gallagher, and I have Wes Dozier with me as well. So if we have questions, we can both maybe field those more fully. So the first item is just kind of summarizing quickly. We are recommending a rate hold on all plans, all tiers for 2024. As you heard from the report before us, Paul did us a favor today. He did a lot of the heavy lift on explaining why that might be so. But a few additional things I'll add. We want a full 12 months of claims with just the county to study to sort of dial that number in a little bit better. Also, the COVID claims have, I think, sort of leveled out. We're seeing the trend positively shift that way. And then finally, you all made some changes to your plan design with the HSA shift, and we're starting to see those things make their way through as well. So we really feel, after studying your situation and consulting with the risk management office, we feel a rate pass is appropriate for 2024. So I'm happy to take questions about that. But yes, Mary?
It's not really a question, it's a statement. I'm glad that there is no rate increase, but I want to go on the record to say, I hope this doesn't bite us next year.
Yeah.
I mean, I get it, and I appreciate that, and especially when it goes to budgeted numbers for that, and I'm happy for the employees that we can. But I say it every year, so I'm going to say it again, because I was here when we went 2 or 3 years and not had an increase, and then we really had a major increase, and that really hurt everybody's pocketbook. So I appreciate this, and I'm all for it. I just also want to go on record to say that we just really need to watch and not, and I'm grateful that we're looking and working towards seeing more months of data before we make any drastic changes or decisions for our employees on our plan.
Can I address that just a minute?
Please, Ed Elam.
Yeah, normally these rates are presented to the committee like in March, April, and we don't have a lot of data to give a good firm number, but it's the best number we have at the time. Just to illustrate is what's coming up a little bit later on the stop loss. Not trying to get ahead here, but think of it with the stop loss, and you try to hit the number the best you can, but like on the stop loss, you're trying to predict somebody who's going to have a high dollar claim in 2024 that hasn't even been diagnosed yet. Now, I mean, let that sink in for just a minute. We're trying to set rates for people who are going to have high dollar claims in 2024 that haven't even been diagnosed yet. So that's where this data is very important. And like Mary said, because of the change and the separation between the Board of Ed and the County General, we've taken a little extra time here to try to get our numbers and to make sure that what we have separated, that the numbers are accurate, and that there's nothing in there that might have an influence on the rates other than what we have in County General. So it's taken a little bit of time, and again, like I said, this is why we've taken a couple of extra months to make sure that that data is here. Keep in mind, we're trying to set 2024 rates with only like 4 months of data from 2023 and to try to develop a trend from it. And so it is. You're right, Mary. When we set the rates, we look at the trend, we hope that it's right. I can just tell you there was a lot of nights that I didn't sleep well during the COVID time because you don't know how COVID was going to affect us and affect our rates. I will share with you, I know I had a discussion with another county. They're looking at 13% increase. Part of that's due to inflation, and they're looking at making some serious changes. What I will say that you're seeing here in this, when Paul says that his book of business is 5-6%, and we're looking at 0, one of the reasons why you're seeing this with us is because of this committee and the commission who made some changes 2-3 years ago, and now we're beginning to see that those changes develop into our claims and the behavior of our members due to those changes. And so we will hit a plateau here. I mean, you're seeing that, but there's going to come a point to where those savings just plateau, and then we're going to get back into the normal trend that everyone has. So that's why we're at 0. It's not because of anything, any particular, other than the great work of this committee and the commission and what we've implemented in trying to do some savings. And Marissa's going to talk a little bit more about some additional savings and what we're looking at, and what this committee is facing. Clinics is one of those that we're doing a deep dive into to see what type of savings we can have there too. If we can go with a different model, or if we just need to, end the relationship with the clinics. So that's one of the things I think's July meeting, Marissa. Yeah, didn't want to jump ahead, but that's just part of what's coming to this committee in July. Will be the discussion on the clinics.
Okay, with that being said, and it helped come back to my memory, this time last year, actually March, we set 11% increase. I think it was 11. And everybody's like, oh my goodness, and we're like, well, we're hoping that we can cover, because at that time we had realized BOE is leaving. So yes, we did that 11%, and it was at the cost of the employees' increase, but now it is come back around that with this no increase, it's kind of a wash between the 2 years. So I guess
yes.
I'm just also kind of putting it out there for general public is last year we did 11 and hoped that we would come in or be stable with it and not have to do another one again, as where everybody thought we should have held it low and then possibly have another one. So I do appreciate what we did and what the commission did on passing that last year, because it has allowed us to sustain this, but it has also come back that we're not having to do another 11%. So I think just kind of a attaboy to all of us. We did good last year by biting the bullet and doing that we can turn around and now do this 0 based on the changes and stuff we've done.
Correct.
So I don't know if Ed, you need an action item on that point, or if you want to take them up together, or.
I'll make a motion to approve the no rate increase for calendar year 2024.
We've got a motion and a second. Let's do a roll call on that, please.
Can I add a little something to that?
Like I could stop you, right?
I'm sorry. But a no rate increase and no plan design change, meaning the deductible and the out-of-pocket. So.
The motion is amended, Michael? And the motion is amended, seconded? Who seconded? Yes. Okay. We have an amended motion and Ms. second. Do you have that? Getting it. Now we'll do a roll call.
Do we need a roll call vote on the amendment?
I want to do that, yes, ma'am.
Okay. Commissioner Boyd? Yes. Amber Brown?
Yes.
Suzette Couples? Brian Gaither? Mary Hickerson? Yes. Lois Miller? Yes. Commissioner McAdoo? Yes. Commissioner Phillips? Yes. Michael Smith? Yes. Steve Spence?
Yes. Motion carries.
All right. The second item that we wanted to discuss today is the stop loss. So Gallagher is recommending that you renew with Cigna for your stop loss for the next year. There are 3 different attachment points to that stop loss. So you all are, having the volume of employees that you have, You're not really in the position where we typically see an aggregate stop loss, so you don't have an aggregate stop loss, but that's in keeping with what we typically see. You have what's called an individual stop loss attachment that is at $300,000 currently. Historically, y'all had it at a higher amount when you had more premium coming in because you were sharing it with the Board of Ed. So you actually had it, I think, around $700,000, if my memory serves. So at this point, you know, you've moved it, when the Board of Ed dropped off, you moved it from 700 to 300. We tend to think that may be a bit of an overcorrection going forward because we're just not seeing that level may be exactly where it ought to be, but we're going to study that more carefully. Paul and the Cigna team have given us additional time to study the attachment point, but we are recommending a renewal with Cigna. I foresee, after some math that we've done on our side, we think you would, right now you've had, depending on which 12-month period you measure from, so if we measure from today, the previous 12 months, or a fiscal year, or a calendar year, I mean, 12 months is a little bit vague unless we really dial in which 12-month measurement period. But you would typically have between 3-4 claimants that would hit that individual stop loss at 300. That's what we would expect. So you all could move your stop loss amount to the $350,000 attachment point, save $133,000 in claim or in premium dollars, but then take a risk on 2.66 additional claimants and still be at break even, to give you kind of an idea. Moving it to $400,000, kind of the same concept, $256,000 in premium savings, but you could absorb an additional number of claims as well that would actually hit that. So I feel like it's probably where we will go, but we don't know at this point. So the recommendation is that we just renew with Cigna and then allow us another 60 days, get another 2 months of claims in. 4 months of claims is not a lot, you know, to study the more recent history, so we'd rather get to about 6 and then decide the final attachment point.
And you have shopped this around outside of Cigna, and, you know, it's still the recommendation to go back to Cigna.
We did not do a formal bid. We decided that we thought that it was within a range of reasonableness, that an additional bid was not necessary.
So how did you make that assertion?
Industry knowledge, relationships, talking with various vendors, and then evaluating what a range of reasonableness would be.
Okay.
You all bid this with Cigna as part of your original bid, so to undo it would be a separate bid, and it would also shuffle the relationship with Cigna. So it's not something you just want to do for a tiny bit of savings. Tiny being relative. It would depend on which level you wanted the stop loss to be and some of those things, but what I'm saying is it is within a range of acceptable reasonableness.
Is it normal? I guess since that question was brought up, is it normal that who our medical is with to also carry or bring to the table the stop loss? Because to me, they're one in this. I know they're different, but they're one in the same, because medical is your claims. You get your claims up to $300,000, then Rutherford County's on the hook for $300,000. $300,000 and a penny rolls over to this stop loss company. So it would look to me like Cigna or Blue Cross or Aetna or somebody like that brings in your medical would be the ones that would bring in your stop loss, because you would want them to kind of be bundled, if you will, so that you've got everybody's talking the same story at the same store, instead of somebody in, upstairs and somebody in the basement trying to talk and save us money.
So that's just called an embedded stop loss. All the big carriers have their own embedded stop loss, but we do see individualized stop loss being shopped with different providers. It's kind of like layering your risk, if you will, kind of, it's like layers to an onion, the interior layers being one way and then the exterior layers being another. But I will say, I think the one a couple significant factors you have to think about. One, it would be the turnaround time for paying the county back. So you will see a little bit more of a lag, typically with an individual external, not embedded stop loss. But if you're talking about a claimant that high and the premium savings were significant enough, you would take the lag time and just float it, right? Typically, that would be kind of the analysis that would be run on that one factor. The second factor, I think, would be, in addition, just the way that the overall contract with Cigna works and the credits and the various things. Right now, it's a total picture where it's all together. So breaking it out would be a reshuffle of that. And again, to make it worth it, you would want to expect to realize a significant savings that would be either something to take back to Cigna to negotiate, or and give them an opportunity to say, no, we'll match that, or to say, it's worth it to separate the two and manage them independently. We have clients at Gallagher who do both. So it just really depends on the situation, if you've got the ability to float, the reimbursement, some of those things, the timing of it, I mean. Great question, though.
Okay, with that being said, are you needing a motion on this, Ed, to stick with Cigna on it? Do we have to choose between 1, 2, and 3, or?
Michael, did you wish to be recognized?
Yes, I make a motion that we renew with Cigna and come back at a later date to choose the stop-loss tier.
We have a motion. Do we have a second? We have a motion and a second. Let's roll call this one too, please.
Commissioner Boyd? Amber Brown? Suzette Couples? Brian Gaither? Mary Hickerson? Lois Miller? Commissioner McAdoo? Commissioner Phillips? Michael Smith? Steve Spence?
Motion passes. Any other?
Can I ask
Of course.
quick question? Michael, we need to vote on the Medicare Advantage rates. Okay, we need to go back and vote on that, whether there is not a rate increase, but we just need to vote on the rates.
That is correct. Thank you. So we got a motion from Michael Smith on the Medicaid Advantage rates. Do we have a second? We have a second. Let's roll call vote that, please, too.
Commissioner Boyd? Amber Brown? Suzette Couples? Brian Gaither? Mary Hickerson? Lois Miller? Commissioner McAdoo? Commissioner Phillips? Michael Smith? Steve Spence?
Motion passes. Ms. Smith, thank you.
Can
Well, Mr. Elam?
one more thing. Do you want to give just a very brief summary of what we're looking at with the clinics?
Sure.
Yes. And what's coming up next?
A couple of things, actually,
Yes.
PBM as well. So to Mary's point, which I think is on all of our minds about, yes, we get a rate hold this year, but how do we continue to manage the health of the plan and really look at various things? There are a couple of potential plan changes that we're going to monitor for next year that we've been talking pretty extensively with Lois and Ed and their teams about, just kind of various things we might look at doing within the plan design, but we don't want to do them yet. It kind of seemed like something we could monitor for a full 12 months before making a recommendation to make those changes. And then in addition, we're shopping the PBM, so you will see a formal bid on the PBM piece. Some of our preliminary numbers look really, really strong on that. So what that is your pharmacy benefit manager, and I know we had a question from the mayor around, specialty and what is falling in each category, and those things are a matter of contract as well. So what the carrier's contract with the PBM provides for which medications go in which bucket, and then what those negotiations are with the various manufacturers. So we are going to be looking at that. There are a number of biosimilars hitting the market, and some new specialty drugs hitting the market as well. Over the next 5 years, there's quite a list of the interchange, and Paul gave a very fair recitation of that. That is absolutely true. That's what's happening. We don't know how that's going to all shake out ultimately, with the new ones coming in that are biosimilars and how that will offset the spend of the new ones that are being developed. We just know that manufacturers spend a lot of time, energy, and money developing the drugs that are going to pay off the most, right? So we expect that there will be quite a bit of shuffle in that area over the next 5 years. So that's one thing we're doing. Another thing we're going to do, and you'll see that bid hit this summer, it does not mean you have to change, meaning we will still compare back to the Cigna situation, and we will account for rebates and that type of thing. We do not anticipate a change of PBM at any point prior to December 31st, so I'll say that. The way that our situation works with Cigna here with your county, it would be that we would carry it through the end of this year and then evaluate something possibly for '24. So if there are questions about the PBM, I'm happy to take those, or we will, and if not, we'll talk about the next item. Okay, so the second item we're looking at is the clinic arrangement. We will be bidding that as well. The contract with your clinic provider was up this fall. I think you all remember we extended that through the end of December to kind of align with the plan year, so that regardless of what decision was made, it wouldn't affect the decision for treatment for a member in the middle of a deductible year or out-of-pocket year. So evaluating for a 1-1, whether we keep a clinic, change the model, perhaps move to more of a telehealth additional benefit as opposed to a full clinic. I mean, there's lots of things to consider there. So we're going to be looking at your clinic arrangement as well over the summer. Those couple of things combined, we think, can yield quite a bit of additional savings. So that's the reason they're being entertained at this time.
Mr. Elam?
Yes, sir.
Anything else?
No, other than I don't think we need a June 22nd meeting. It's on the calendar, but I don't think we'll need one for June 22nd. So we'll
Are
send
there
out a
questions
notice for
from,
July.
any other questions for Ms. Smith?
Our plan is the July 26th meeting that we will have these couple of things back up before you.
Okay. Thank you. Finally, other business. Yes, ma'am.
Actually, I have a other business question, but back to when Michael and I made the motion to approve the rates, did we include the dental and vision in that? Was that going to be an overall? That's what I'm assuming. I just wanted to kind of put it on the record. That was all in one. Okay, with that being said, my other business is, I know that we made a change last meeting to our cybersecurity, increased our dollars to save some money, so based on the major employer within Rutherford County that was hit, and I know this is more than insurance, but we voted for the policy and the coverage, is there any, did we make a good choice in changing and raising our what we're going to be in charge of paying out if this happens? And I know Cody and them in OIT have been working on this, but I'm assuming it all went through commission the way I seen and heard and listened on the passing, but are we getting any pushback on making that change now that we've had a significant employer within Rutherford County get hit?
So let me comment on that. Another employer that you're talking about, no, we haven't gotten any pushback. Is it possible that we made the best choice? Absolutely. Is it possible we could have find out downstream we could have made a better choice? Hindsight is always 20/20. I will tell you this, I'm comfortable with the recommendation that I get from both Mr. Elam and Mr. York, and because cybersecurity is such a fluid issue, and it literally changes every day. And Ed and Cody and I have talked about this. If there's one issue that chronically keeps me awake during the course of a week, it's cybersecurity. It may be possible, Mary, that we have to make a course adjustment sometime down the road. And I will come back before this committee and the county commission and say, hey, we need to make a course adjustment. And I'm sure that this committee and the county commission will consider that. But I'm satisfied we made the right choice for right now. So, but I again, with regard to cybersecurity, my feet is cast in jello. Okay, so I want to make sure we have the ability to make a course correction. So I'm glad you brought this up because that's exactly where I'm at. Did you want to say something, Commissioner? Your microphone.
June 22nd meeting canceled, or will it be canceled?
It is canceled.
If there are no
Unless somebody wants to vote to have it.
If there are no objections, Mr. McAdoo, I'll entertain a motion. We are adjourned.